This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Neurosurgical Review, published in 2026, titled Bilateral Decompressive Craniectomy in Pediatric Patients, a Systematic Review.
This is a topic that hits home for anyone covering a pediatric trauma center. We've all been there. A young patient with severe traumatic brain injury, or TBI, where the intracranial pressure, or ICP, just won't stay down despite maximal medical therapy. We start talking about decompressive craniectomy, or DC, as a salvage intervention. But while we have big randomized trials in the adult world, the pediatric data for bilateral approaches is, well, it's a bit of a black box.
Exactly. And that's what Levin Carrion and the team from Rutgers and other institutions wanted to tackle. They performed a systematic review following PRISMA guidelines to see what we actually know about bilateral, bifrontal, bitemporal, and even cruciate decompressive approaches in this population.
Before we get into the results, let's talk about the why. Why do we need a specific look at the pediatric population? Why can't we just use the adult data?
The authors make a great point right in the introduction. Pediatric patients are uniquely vulnerable to acute intracranial hypertension. Unlike our older patients, children often lack the degree of cerebral atrophy that provides that compensatory intracranial reserve. Their brains are tight, their skulls are developing, and their cerebral compliance is entirely different. While first-line management, optimization of ventilation, osmotic therapy, sedation, and CSF diversion is similar to adults, the stakes for secondary ischemic injury from sustained ICP elevation are incredibly high in a developing brain.
And that brings us to the surgical taxonomy. When we say bilateral, we might be talking about a few different things. Did the study specify the techniques they were looking at?
They did. They searched for studies reporting on bifrontal, bitemporal, bilateral, or cruciate decompressive craniectomy. They defined pediatric or young adult as age 21 or younger.
That's a broad range, but it captures that transitional physiology. So how much high-quality evidence did they actually find?
Honestly, Aris, it's sparse. Out of all the literature searched across PubMed, Scopus, Embase, and PMC, only 5 studies met the final eligibility criteria for the primary synthesis. That included 1 small randomized pilot trial and 4 observational cohorts.
Only 5? That really highlights the clinical and methodological heterogeneity the authors mentioned. Let's dive into that. What were the main takeaways from these 5 studies?
The most consistent finding across the limited reports was that bilateral decompressive strategies are feasible as salvage intervention for refractory ICP. In the cases where it was used, mostly severe TBI or diffuse cerebral swelling, early decompression was associated with a reduction in ICP. 1 small randomized trial suggested it might lead to favorable outcomes, but the overall evidence remains insufficient to claim superiority for any one technique.
Let's talk about those techniques. You mentioned cruciate craniectomy. That's not something we discuss every day in the resident room.
It's one of the more aggressive approaches mentioned. The review looked at bifrontal and bitemporal as the more common bilateral strategies, but the cruciate approach is part of that specialized armamentarium for the most extreme cases of diffuse edema. The problem the authors found is that many larger pediatric DC studies often lump bilateral or bifrontal patients into a small subgroup, and they don't always stratify the outcomes by the specific technique used. It makes it very hard to say, in this specific injury pattern, a bifrontal is better than a bitemporal.
Right, the taxonomy is a mess. If we can't agree on what to call the procedures or how to report them, we can't compare them. Now, as a surgeon, I'm always worried about the price of these big decompressions. What did the systematic review find regarding complications?
The complication profile is significant. They reported varied rates of hydrocephalus, subgallic collections, and the need for reoperation. Because these are salvage procedures, you're often dealing with a worst-case scenario brain. The review notes that while mortality and functional recovery varied, the lack of standardized reporting for complications makes it difficult to pinpoint the true risk-benefit ratio for the bilateral versus unilateral approach in children.
It's the classic neurosurgical dilemma. We might save a life by reducing the ICP, but what is the quality of that survival? Did the paper touch on neurocognitive outcomes?
They mention that long-term neurocognitive outcomes are one of the biggest gaps in the current literature. Most studies focus on short-term survival or the Glasgow Outcome Scale at discharge or 6 months. But for a 10-year-old, we need to know how they're doing 10 years later. The authors explicitly call for prospective studies that include these long-term neurocognitive metrics.
That's a vital point for our residents to hear. We aren't just treating a number on the ICP monitor. We're treating a person with 70 years of life ahead of them. So, Ilara, if a resident asks you tomorrow, Based on this 2026 review, when should we pull the trigger on a bilateral DC in a teenager? What's the answer?
The answer is that it remains a salvage intervention for cases refractory to maximal medical therapy. The paper emphasizes that while it is feasible, we still don't have a definitive optimal timing or a specific ICP threshold that mandates a bilateral approach over a large unilateral one. It really comes down to the individual injury pattern, specifically diffuse cerebral edema or bihemispheric swelling.
And did they find any consensus on the how? For instance, bifrontal versus bilateral hemicraniectomies?
Not a definitive one. The evidence was too heterogeneous. Some studies favored bifrontal for diffuse frontal swelling, but because of the clinical differences between the 5 included studies, the authors stated that definitive conclusions regarding efficacy, optimal timing, or superiority of one bilateral approach cannot be made.
That's a bit frustrating for the clinician, but it's an honest reflection of the literature. It's a call to action. What did the authors suggest for the future?
They were very specific. We need prospective multi-center studies. Specifically, they want to see standardized age definitions, using that age of 21 or younger consistently, standardized ICP thresholds for surgical intervention, and a standardized operative taxonomy. We also need better, more consistent complication reporting.
I like that term, operative taxonomy. It's hard to do a meta-analysis when one surgeon's bifrontal is another surgeon's bilateral craniectomy with a bone bridge.
Exactly. And they also emphasize that we need to separately extract pediatric data from mixed-age studies. A lot of the data we could have had was lost because researchers mixed 15-year-olds with 40-year-olds and didn't provide a way to separate the outcomes.
That's a common pitfall in trauma research. So to summarize for our listeners, bilateral DC in kids is a tool in the shed for refractory intracranial hypertension. It works to lower ICP, it might save lives in selected cases of diffuse swelling, but we are still in the dark about the best way to do it and the long-term cost to the patient's functional status.
That's a perfect summary. The paper basically highlights that while the procedure is a mainstay in the salvage category, the neurosurgical community has a lot of work to do in terms of high-quality, prospective, and standardized research.
That's a great reminder that even in 2026, some of our most common heroic procedures are still waiting for a solid evidence base. For the residents listening, if you're looking for a research project, standardizing the reporting of these bilateral decompressions is a wide open field.
Definitely. It's an area where even small, well-defined prospective cohorts could make a massive difference.
Thank you, Dr. Alara. This has been a great deep dive into the 11 carry-on systematic review.
Thank you, Dr. Aris. It's always good to look at the data, or the lack thereof, behind what we do in the OR.
That's all for today's episode of the Neurosurgery Hub podcast. Stay sharp, keep reading, and we'll see you in the next episode.
Goodbye, everyone.